Good morning, everybody. My name is Dan Elliott. I'm chair of the CTAF panel. To my left is Steve Pearson, who is president of ICER. And I'd like to introduce Karen Shore, who is our program director. Karen?
Thank you, Dan. And welcome. Good morning, everyone. So I'm Karen Shore, and I work for the Institute for Clinical and Economic Review, known as ICER, and am the new program director for CTAF. So this is my first meeting. Be gentle. So it's my pleasure to welcome everyone today, the CTAF panel, the policy roundtable participants, several ICER staff and consultants, and then the audience in the room. So welcome to you all, as well as to folks on the live webcast. So we're webcasting today, and we have people watching from Alaska to Massachusetts. So welcome to everyone on the web as well. So let me start with some logistics. For those of you in the room, please help yourself to refreshments in the back and avail yourself of the restroom as needed. They're out the door and to the left. We have only one break-ish on the agenda today, and Steve will perhaps move the agenda around a little bit. So there will be a working lunch this afternoon. And before we get started, please put your cell phones on vibrate. And for the panel and for the policy roundtable, who will be up in front this afternoon, the mics turn on and off with the push button. Please try to leave them off when you're not speaking. That'll help with the webcast quality. So today we're talking about new treatments for hepatitis C. And for the CTAF panel and the policy roundtable, you have a set of handouts that have the evidence presentation slides as well as the voting question slides in your packet. And everyone else here has an agenda, a set of key tables from the report, a list of the voting questions, and then two documents that have comparative prior authorization criteria. For those listening on the webcast, you can download those materials from the CTAF website, and the presentations will be posted on the CTAF website after the meeting. So this is a brief overview of the agenda for today. We'll have the presentation of the clinical evidence this morning, and the cost modeling, and then followed by a lively policy roundtable discussion this afternoon. And for those interested, you can download the meeting materials at the bottom of the page there, tinyurl.com/CTAF-HepC. So especially for folks on the webcast who don't have easy access to the materials. So with that, welcome again, everyone. Thank you for joining us. And Dan, I will turn it back to you.
Thanks, Karen. I'd like to add my welcome to everybody. Just a word about CTAF, the California Technology Assessment Forum, a flagship initiative of ICER, the Institute for Clinical and Economic Review, develops rigorous evidence reports and provides a public venue in which the evidence on the effectiveness and value of healthcare services can be discussed with the input of all stakeholders. CTAF's mission is to help patients, clinicians, insurers, and policymakers interpret and use evidence to improve the quality and value of healthcare. Our vision is to help create a future in which collaborative efforts to move evidence into action provide the foundation for a more effective, efficient, and just healthcare system. Just a word about conflicts of interest. In response to our inquiries, no CTAF panel member has a conflict of interest with respect to the subject of this meeting. Are there any updates to this statement among the panelists? Okay, so we would ask our speakers, including the policy roundtable participants and individuals making public comments, to announce their conflicts of interest, if any, when they speak. And now I'd like to turn the meeting over to Steve Pearson.
Hi, good morning again to everybody on the panel and in the audience and on the webcast. I'd like to give a special welcome to the new members of the CTAF panel. We have 7 out of the group who are at their first CTAF meeting. We've picked an especially easy topic with just straightforward evidence issues and nothing else. So you'll get your feet wet and we'll pick up and get harder from here. We often get asked how we pick topics for CTAF, and I think obviously the new drugs for hepatitis C are a great example. Hepatitis C is a common condition with consequences that are very important for individual patients and for public health. It's a very costly therapeutic area right now, and the evidence is controversial. And as many of you know, hepatitis C drugs have kind of become an example of the tension that we face between issues of innovation, patient need, access, and affordability. So for us, it's an opportunity to have CTAF try to provide some guidance to all decision makers in the healthcare system. And to do that, the process for today is designed with objective review of the evidence at its source. So the course for today will begin with Jeff Tice, clinical epidemiologist and associate professor at UCSF, presenting the evidence review on clinical effectiveness. Then Dan Ohlendorf, the chief review officer for ICER, will discuss the findings from the model that tried to scan out the effects both clinically and economically downstream. Then we will have a slight change to the agenda. We'll have the patient comment phase from 11:30 to noon, because we thought it would make for a better flow if we did that, and then we will break to get lunch and bring it back for the working lunch. So from about noon to 1:15, we'll have the opportunity for the panel to ask questions of both Jeff and Dan, and of the members of the Policy Roundtable that we will invite up for that phase. And the Policy Roundtable we'll introduce later, but they include representatives from patient groups, from payers, from provider groups, and from manufacturers. So we'll do all that, and then following that Q&A, we'll have the voting phase at which the CTAF panel will vote on specific questions related to the effectiveness and value of different treatment options for patients with hepatitis C. And then we'll have what we call our Policy Roundtable, which will be the phase when, again, with the Policy Roundtable in dialogue with the CTAF panel, we'll really explore how we want to apply the evidence as we have reviewed it today to the key questions about the delivery and coverage of these drugs and how patients can be involved all along the way. So that's the course for today. And with that, I'd like to introduce again Dr. Jeff Tice to kick us off.
Thanks, Steve. Hello, everybody. It's great to be here. This is a complex topic, and I'm going to try and distill it down in a few slides. We've left out most of the background, but I am going to go over a little bit of background information just because it sets the structure really for our discussions today. I have no conflicts of interest, but I did want to acknowledge one of our clinical experts, Dr. Irina Fox, who will be on the Policy Roundtable. I grabbed a couple of her slides from a talk she gave, and I've made some slight changes, but I wanted to acknowledge that some of my slides came from her, as well as a website that provides free slides to clinicians, allows us to use them, clinical care options, but they had a few things that were just easier graphically. They did a really nice job depicting things, and so I wanted to acknowledge both those sources for a couple of slides. So HCV, as you're all aware, has a number of different genotypes. I put this up because it structures our talk. The majority of Americans who are infected with hepatitis C carry genotype 1, 70 to 75%. I just rounded numbers here. The estimates vary a little bit depending on the source. Genotype 2 is about 15% of infected Americans, genotype 3, 10%. So that's almost 99% of infected Americans are those three genotypes. And our review just focused on those three genotypes, not 4 through 6. And responses to therapy, and in fact the indications for therapy, are also genotype based. So the presentation of the evidence will be structured by genotype. And then I also wanted to put up just the natural history of hepatitis C infection. These data are from the CDC. Their estimates, mostly from NHANES data, the National Health and Nutrition Examination Survey. Of 100 people infected with hepatitis C, about 20 or 30% will develop symptoms, which means that 70 to 80% are asymptomatic after infection, never know that they have the infection. But the majority of people, estimates vary between 75 and 85%, will develop a chronic infection. The rest will clear the infection after the initial exposure. Again, out of that 100, 60 to 70% will go on to develop some degree of chronic liver disease, elevations in liver enzymes, some degree of scarring, of fibrosis of the liver if we do liver biopsies. And over 20 to 30 years, the estimates are between 5 and 20% will go on to develop cirrhosis, and about 1 to 5 of those 100 people who were initially infected will die from cirrhosis or the complications of cirrhosis or hepatocellular carcinoma. So that's the overall landscape. And the 20 to 30-year time frame is actually relevant, as you saw in the review, and most of you are undoubtedly aware. The majority of patients people in the United States who were infected were born between 1945 and 1965, so have had the infection for 40 or more years, so are at high risk now for cirrhosis and the complications associated with cirrhosis. This is the landscape of treatments for chronic hepatitis C infections. 1991, interferon was approved. Then it was found that ribavirin added to interferon markedly improved response rates to therapy. And then pegylated interferons, which allowed a once-a-week injection rather than 3 times a week injection, was introduced. But then we had 10 years of no additional treatments. Just 3 years ago, I guess now, in 2011, 2 drugs, boceprevir and telaprevir, were introduced, which directly target a protease in the hepatitis C genome, and it's a real step forward. Lots of excitement at that point. And as you know, in the end of 2013, in November and December, cimeprevir and sofosbuvir, the drugs that we're going to talk about, were approved. And then going forward, there are several additional directly acting antiviral therapies that should be approved in this next year. And certainly by 2015, there should be a number of interferon-free combination therapies of direct acting antivirals available. So we're just seeing the tip of the iceberg. In a couple of slides, I'll show a number of the other drugs that are in the pipeline currently. So clearly our goal, as the natural history slide showed, is to prevent cirrhosis, the sequelae of cirrhosis, and hepatocellular carcinoma. And interferon and ribavirin has been the backbone of therapy until really today. For the clinical trials we're going to consider, all of the clinical trials are based on a surrogate outcome, sustained virologic response. Traditionally, I think I have this on the next slide, it's been an SVR of 24, which means 24 weeks after the end of therapy. Can you detect any RNA in the blood? If you cannot, that's considered a sustained virologic response at 24 weeks. The more recent clinical trials, the FDA has allowed an SVR of 12, so 12 weeks after the end of therapy as the surrogate outcome. And this is a reasonable surrogate outcome. We'll go over the data. It appears to essentially be curing patients of the infection. These data are an example from one of the studies of cimeprevir, a phase 2 trial of cimeprevir, the PILAR study, and it looks at 366 patients who had no detectable virus at week 0, so at the end of treatment. This is the week number refers to when treatment was finished. At 12 weeks, so the SVR 12, 90% of them were still free of evidence of virus, but 10% of the patients had relapsed. If you go from 12 weeks to 24 weeks, so this is the change in the surrogate outcome in the recent trials, you go from 90% to 89%, so not a big drop. So SVR 12 seems a reasonable approximation of what has been the standard SVR 24. And if you follow patients out to 72 weeks, so 48 weeks after the SVR 24, you do lose a few patients. It drops down to an SVR of 87%, though some of this is due to loss to follow-up in this study, so it's unclear still whether it might actually be a little bit better than this. And in a prior meta-analysis that looked at long-term cure after SVR24, that SVR was maintained for the long term in 98 to 100% of patients. So it appears to be a reasonable surrogate for remaining free of hepatitis C virus in the blood for the long term. But the big question is a sustained virologic response is clearing the virus associated with a reduction in outcomes that we care about: death from hepatocellular carcinoma, progression to cirrhosis, and death from cirrhosis-associated liver decompensation. This is one example of 530 patients who were followed for a little more than 8 years after treatment. About a third of them achieved a sustained virologic response at 24 weeks in this case. And when you compare those who had an SVR24 to those who did not, there was a 74% reduction in all-cause mortality, death from any cause, in those who achieved a virologic response, a sustained virologic response, and there was a 94% reduction in liver-related mortality in transplant. There are several other studies looking at this. One showed very similar numbers. The VA trial, which was retrospective, didn't quite have as robust a definition of SVR. The outcomes weren't quite as good, but there is clearly a marked reduction in mortality and liver-related complications associated with SVR. Current treatment, as I mentioned, pegylated interferon, that's the P, and ribavirin, that's the R, have really been the mainstay of therapy, particularly for genotype 1. You're treated for 48 weeks, and about half of patients, a little less than half of patients, achieve a sustained virologic response, so 40 to 50% in the randomized trials. And this is important. Most of the data we're going to consider today are randomized trials, but in real-world studies, where patients aren't as motivated and don't maybe get quite as much support as those who are enrolled in randomized trials, the SVR24 has tended to be lower with pegylated interferon plus ribavirin, more on the order of 25-30%, so about a 20% reduction compared to what we see in the randomized trials. And then there are many, many contraindications, as all of us know. People with significant psychiatric illness really are not considered candidates because interferon in particular can exacerbate that. Patients with autoimmune disease, again, interferon affects the immune system and may exacerbate autoimmune disease. And patients with advanced liver disease decompensation are also not candidates. There are also terrible side effects. Interferon is, the substance, the cytokine that the body produces when you have a viral infection. So essentially you have a viral infection for 48 weeks and all of the symptoms that go along with that: fever, fatigue, body aches. And then ribavirin is associated with a hemolytic anemia. So a large percentage of patients develop clinically important anemia, and patients also develop depression and anxiety. In 2011, as I said, the first of the direct-acting antivirals were approved, boceprevir and telaprevir. They improved that SVR24 from the 40 to 50% range up to 70 to 75%, so a big jump, about a 30% improvement. And there's also the introduction of response-guided therapies. Patients whose viral load drops very early in therapy are eligible for 24 weeks rather than 48 weeks of interferon and ribavirin, so that's also an improvement, somewhat shorter duration of therapy. However, this comes at a cost. Either you need to take 2 or 4 pills every 8 hours. And it can't be 3 times a day. It really needs to be spaced out just about every 8 hours, so patients have to be on a schedule with timers going off reminding them to take the pills. So it's a real burden and a lot of pills. You need to take a special diet with the pills to enhance absorption. And that anemia, which was already a problem in about a third of patients, now goes up to about half of the patients with a significant anemia, meaning a hemoglobin of 10 or less. And then there are a number of other issues with taste disturbance, significant rashes, and a lot of drug interactions, particularly with medications used for the treatment of HIV. And there is a large portion of patients who are co-infected with HIV and hepatitis C. So many, despite the improvements in SVR, there are a lot of difficulties with delivering this therapy. For genotype 2 and 3, the situation is somewhat better. The SVR24 is on the order of 75 to 80%, at least in the randomized trials, and it only needs to be given for 24 weeks. So shorter therapy, higher response rate, but you still do have to take 24 weeks of a difficult to tolerate combination therapy. So the new antivirals, as I said, there are many drugs coming down the pipeline. The first two approved, telaprevir and boceprevir, are protease inhibitors of this particular protease. Cimeprevir, one of the drugs we're going to consider today, also is an inhibitor of the same protease. There are a number of other ones on track for approval soon. The first polymerase inhibitor that's approved is sofosbuvir, and we'll talk about that today. There's another one in the pipeline, and then there are a number of other related medications that many of which have published data, and some of which will be approved in the next year or two, most likely. So cimeprevir, the first drug, this was, as I said, similar to telaprevir and boceprevir. It's a protease inhibitor. It was approved in November of last year, only for use in genotype 1. It's only been studied, effectively only been studied in genotype 1, and it requires interferon and ribavirin. So it's in combination with those two drugs for a total of 24 to 48 weeks. Again, using the response-guided therapy approach, if the viral load drops early and is maintained at a low level, then the pegylated interferon and ribavirin can be stopped at 24 weeks rather than 48 weeks, and a little over half of patients appear to respond in that way. The real advantages, it's a one pill a day regimen, so much easier to take and a little bit easier to tolerate than the first generation protease inhibitors. Sofosbuvir, as I said, is a novel class of drugs. It's a polymerase inhibitor. It was approved 1 month after cimeprevir, so December of 2013, and it received breakthrough designation from the FDA in part because of improved response rates, but in particular, I think, because of the fact that some of the drug regimens do not require interferon, and thus it dramatically reduces side effects associated with therapy. It's indicated for all HCV genotypes, and it's been approved for use with interferon, particularly for genotype 1, and without interferon for genotype 2. It's also approved in HIV, HCV co-infections. So with that background, lots of background, but we will now turn to the evidence. I'm going to start focusing on genotype 1, and I want to point out there are no head-to-head trials of any of these drug regimens incorporating cimeprevir or sofosbuvir with the current standard of care, which should be pegylated interferon plus ribavirin in conjunction with one of the two first-generation protease inhibitors, boceprevir and telaprevir. And that really reflects the fact that at the time these studies were designed, boceprevir and telaprevir weren't approved, they weren't standard of care. But it is a real limitation of the evidence. There are also no head-to-head trials between these two drugs. And to try and level the playing field, we performed a network meta-analysis which allows for indirect comparisons because each of these drug regimens have been compared to pegylated interferon and ribavirin alone, and you can make sort of indirect comparisons based on the relative response rates of the pegylated interferon ribavirin arm in each of the studies. And we'll go through that in a minute. Another significant limitation is the fact that there are really no studies that have been performed with long enough follow-up to look at the outcomes we really care about: progression to cirrhosis, decompensation of liver disease, or the incidence of hepatocellular carcinoma, or transplant or death, the outcomes we really want to impact for patients. In genotype 2 and genotype 3, the analysis will be much easier. Boceprevir, telaprevir, and cimeprevir are not approved for genotypes 2 and 3, so we really are only comparing sofosbuvir to the pegylated interferon and ribavirin arms. And the sofosbuvir regimens are all interferon-free here, so have the advantage of the loss of all the side effects associated with interferon. The clinical outcomes, the primary benefit that we'll look at is just the sustained virologic response at 12 weeks or 24 weeks after the end of therapy, a surrogate outcome. So that will be important to keep in mind when extrapolating these benefits to clinical outcomes. And the primary harms are really the adverse events during treatment and the treatment burden with interferon. It requires injections once a week and then lots of pills for the standard therapy with boceprevir or telaprevir in genotype 1. So cimeprevir, there are 7 randomized trials with, that are controlled with pegylated interferon and ribavirin as a control. 3 of these were phase 3 clinical trials using the FDA-approved dose. The 3 names are here: Quest 1, 2, and Promise. Quest 1 and 2 are in treatment-naive patients. Promise is in treatment-experienced patients. All of the trials are in patients with genotype 1 hepatitis C infections, and all patients were interferon eligible because the control group in these cases included interferon. There are also 5 additional uncontrolled trials. For sofosbuvir, there are 3 randomized trials using PR as a control. One of those is a phase 3 trial in genotype 2 and 3. That's the Fission trial. Most of the others included a mix of genotypes 1 through 3. And of course, all of these patients were interferon eligible because one of the groups they were randomized to included pegylated interferon. There are 10 additional trials, one of which was a placebo-controlled phase 3 trial for patients with genotype 2 and 3 who were not eligible for interferon either because they were intolerant from past experience, they were unwilling to take interferon, or were ineligible because of contraindications, and that trial is the positron trial. So genotype 1 will start focusing on treatment-naive patients, so patients who have not been treated before for their infection, who are eligible to receive interferon. So, these are going to be structured along the same lines as the voting questions that you'll be asked to deliberate on this afternoon. This is a depiction of the network meta-analysis. The size of the circles represents a number of patients treated with the regimen. So the largest one is patients treated with pegylated interferon and ribavirin. This is cimeprevir plus pegylated interferon and ribavirin, and the thickness of the lines connecting the circles reflects the number of patients in the randomized trials comparing those 2 treatment regimens. So you see all of these 4 newer regimens are compared to pegylated interferon. There are no trials. In some network meta-analysis, you also have comparisons between other groups. In this case, we have no data directly comparing any of the alternatives to pegylated interferon and ribavirin. The results of the network meta-analysis are here. It's a little bit different than what was in the original write-up in the sense that the cimeprevir group, we've excluded patients who have a mutation which makes the virus not susceptible to cimeprevir. So in the interest of fairness and reflecting the treatment guidelines that are out there, most of the treatment guidelines say if you're going to use cimeprevir, check for this mutation and don't use it if the virus has the Q80K mutation. So in order to more accurately reflect clinical treatment using these regimens, we've excluded those. So when we do that, we see that on average, as expected, patients treated with pegylated interferon and ribavirin have between 45 and 50% reduction in or SVR 12 in this case. Boceprevir and telaprevir increase it to 25% up to 73, 74%. And the newer regimens have about a 10% increase in SVR compared to the older PR regimens. If these comparisons are correct, if these indirect comparisons and the extrapolations from them are borne out in actual head-to-head studies. I wanted to note that this estimate for sofosbuvir plus PR is somewhat lower than reported in the individual trials. And that's because 3 of the trials that went into this had no PR arm. So we had to guess what the response rate would be if the patients in the sofosbuvir treated groups actually received PR alone instead of sofosbuvir plus PR. And we elected to use a conservative estimate. We didn't use the estimate of 47% as is typically seen across all studies. We used the same response rate that was seen in the one study that had a response, that had a PR arm, and there the response rate was 58%. So the group had a much higher, with 58% reduction, or SVR 12 with PR alone, so higher than traditionally seen. And since we assumed that for all of the sofosbuvir trials, the sort of incremental benefit compared to 58 is sort of what then gets reflected here as an incremental benefit in response to 47%. So it's a little bit lower than reported in the trials. And it could be that they picked, there are many predictors of response to pegylated interferon and ribavirin, and it may be that patients in these trials had fewer of the poor prognostic indicators, and that's why their response rate was 58% in that one trial of sofosbuvir. And I will point out one of the trials of cimeprevir had a PR response rate, SVR 12, of 65%, so it did even better. So there is somewhat some variability in the response rate depending on characteristics of the individual patients in the trials. So a lot of uncertainty. We picked a number, and there certainly can be debate about that. So harms. The data for cimeprevir are mostly presented in the cimeprevir plus PR versus PR for the first 12 weeks of therapy and don't include the additional treatment with PR alone. In that 12-week period, there were fewer adverse events requiring treatment to be stopped in the comparative trials, 2.6% for cimeprevir plus PR versus 4.5% for PR alone. That probably wasn't a significant difference, and essentially the addition of cimeprevir did not result in any additional adverse events leading to the drug being stopped. For the common adverse events, the things that we see with interferon and ribavirin, the fatigue, the fever, other flu-like symptoms, there are really no important differences between the two groups. There was a little bit more photosensitivity in the cimeprevir group, 3.3%, and elevated bilirubin. These are known side effects associated with cimeprevir therapy, but this did not translate into a reduction in treatment. For sofosbuvir plus PR, in the data that was available, again, there were fewer AEs requiring stopping of treatment, 2% versus 11%. This mostly reflects the shorter course of therapy. It was 12 weeks of sofosbuvir plus PR versus 24 weeks of PR alone. The other side effects were comparable. So the addition of sofosbuvir to PR did not appear to significantly increase side effects. For cimeprevir or sofosbuvir versus telaprevir or boceprevir-based regimens, we have no direct data, but there are clearly fewer pills, and there appears to be less anemia, though we don't have any direct comparisons to really know whether that extrapolation is correct. So those are the data that will go into the decision-making about the clinical efficacy of the newer regimens for treatment-naive interferon eligible patients. For interferon ineligible patients, there are no controlled studies. There are no studies at all of cimeprevir without interferon. There's no indication for cimeprevir without interferon. There's 3 small studies of sofosbuvir plus ribavirin alone for either 12 or 24 weeks, the largest of which is relatively small, 25 patients. The SVR ranges from 47 to 84%, but there are likely fewer adverse events and certainly no injections, so less likely fewer adverse events than if you were comparing it to pegylated interferon and ribavirin. If these patients are ineligible for interferon, so would only be eligible for ribavirin alone, that's not an effective treatment for hepatitis C. So that SVR of between 47% and 84% is a big step forward for those patients. But lots of uncertainty. They're uncontrolled trials and relatively small. So now we're going to move to the second set of genotype 1 patients, those who are treatment experienced, those who've already been treated mostly with pegylated interferon and ribavirin, though of course there are patients who failed PR plus either boceprevir and telaprevir. But most of these trials reflect patients who failed initial treatment with pegylated interferon and ribavirin. So again, no direct comparisons. We did the same network meta-analysis in order to make indirect comparisons between, for example, cimeprevir and pegylated interferon plus ribavirin to, say, cimeprevir plus sofosbuvir, because both have been compared to PR. So we sort of make this triangulation to estimate a response here. And the output of the network meta-analysis is here. And again, the one change from the initial results were for cimeprevir, we've excluded patients with a Q80K mutation. So as expected, patients who've already been treated with pegylated interferon and ribavirin, they don't respond very well to a second round of treatment, though about 1 in 5 do have a sustained virologic response. When you add boceprevir to that, you get a big increase, up to 64 to 70%. Cimeprevir and sofosbuvir, so cimeprevir in the network meta-analysis appeared to be about as good as telaprevir and boceprevir. So 70% response rate among patients without the Q80K mutation. Sofosbuvir, we have no data. So the sofosbuvir plus PR or sofosbuvir plus other regimens weren't included in this because there are no data. We also included one small study, the Cosmos study, that used a combination of cimeprevir and sofosbuvir. There were 4 arms, 2 with ribavirin, 2 without. 2 were for 12 weeks, 2 for 24 weeks, and the combined SVR12 in the 80 patients was 90%. We used an estimated PR of 22% for this comparison, so that's why the network meta-analysis estimate comes out exactly the same as the pooled data in this study. That appears to be the most effective regimen in patients who are treatment experienced, but based on a study of 80 patients, and there were 4 different treatment regimens used among those 80 patients. The FDA modeled or estimated an SVR for sofosbuvir plus PR based on data from treatment-naive patients. And they have prior evidence, mostly with boceprevir and telaprevir trials, suggesting that in treatment-naive patients who have poor prognostic indicators, the combination of several ones, the SVR estimate in treatment-naive patients who have those poor prognostic indicators is about the same as the SVR for treatment-experienced patients. And the FDA made this extrapolation based on 52 patients in the neutrino study who had poor prognostic indicators. And in that study, the SVR12 was 71% for sofosbuvir plus PR. So that is the estimate used by the FDA for approving sofosbuvir for this indication. So those are the data on the SVR12. The harms are really the same as for the treatment naive. There's really no difference in the drug regimens, and the adverse events really are the same, so really no difference here. For treatment-experienced patients who are interferon ineligible, the network meta-analysis all was comparing to patients who received pegylated interferon and ribavirin, so they were all interferon eligible. So among interferon ineligible patients, there are no controlled studies, and there are no studies of cimeprevir or sofosbuvir alone, except when the two are used together. And again, that's that Cosmos trial that I described, where the combination of cimeprevir and sofosbuvir for 12 weeks or 24 weeks with or without ribavirin was investigated. And if you pool the results from all 80 patients in that trial, the SVR12 was 90%. Just to flesh out the full Cosmos experience, this is actually one of two cohorts. All of these patients actually had not responded to prior therapy, but had relatively, I'm going to make sure, low grades of fibrosis. So they had fibrosis scores of 0 through 2. There's a second Cosmos, or second cohort of the Cosmos trial for patients who have more advanced fibrosis, F3 or F4. Those data have only been presented in SVR4 with SVR4 results, so we did not include them in our analysis, but just so that everyone's aware, there's a second Cosmos study that's out there for patients with more advanced fibrosis. So clearly, there are relatively few AEs and no injections with this interferon-free regimen. It had a high SVR12, so seems quite promising. There aren't a lot of data yet on the adverse events, and it's a relatively small study, but lots of press, and clinicians are using this combination now clinically. So, breathe a sigh of relief. That's all of the complication. Genotype 2 is much more straightforward, as is genotype 3, a little more complication in genotype 3, but no cimeprevir, no boceprevir, no telaprevir, and no network meta-analysis. So for genotype 2 treatment-naive patients, there is a phase 3 randomized trial, the Fission trial. 137 patients were genotype 2, treatment-naive, and were compared to pegylated interferon and ribavirin. So this is the more standard kind of data we're used to looking at in randomized trials. The combination of sofosbuvir for 12 weeks and ribavirin for 12 weeks had a 97% SVR12, so quite high. Pegylated interferon and ribavirin alone for 24 weeks, 78%, so in the range expected for genotype 2 with that combination. And you had many fewer patients stopping therapy because of adverse events, most likely because the sofosbuvir-based regimen does not include interferon. An example, just one example, is the number of patients reporting flu-like illness was about 3% in the sofosbuvir-based regimen versus 18% in the interferon-based regimen. So marked reduction in adverse events, in stopping therapy due to adverse events, shorter therapy, and a higher SVR12. So quite promising and much less confusing. And I should say this should also translate into the responses for interferon ineligible patients, though the benefits are even greater because the interferon ineligibles are not eligible for the PR. So the improvement in outcomes would be 97% versus most likely 0% in the comparison group. For treatment-experienced patients, there are two uncontrolled trials. So we do not have randomized trial evidence. We have data from the Valence trial and the Fusion trial. The estimates of SVR12 from those two studies were 86 and 90%. For the modeling that Dr. Ohlendorf will present later, we used 88% for our estimates. Again, assuming that patients could be retreated with pegylated interferon and ribavirin, you would expect some benefit, but you would expect similar harms was seen in the treatment-naive patients, and so a marked reduction in adverse events. So you should see higher SVR12, fewer side effects, and a shorter treatment with the sofosbuvir-based regimen in genotype 2. Genotype 3, so the treatment-naive patients, there's no direct evidence, there's no randomized trial. In the fission trial, which was the randomized trial, there was no difference in SVR12 between those who received the sofosbuvir-based regimen versus the interferon-based regimen. The AEs were lower. But there was no benefit to sofosbuvir versus PR other than the reduction in adverse events. The SVR12 was not better. This was oh no, I'm sorry. Yeah, that was just context. But so that in genotype 3, they realized that the 12-week therapy was probably too short. Did a 16-week trial, 24-week trial, and I'm sorry. So these data reflect the 24-week data from the Valence trial. Much higher SVR12. This is the FDA indication for sofosbuvir in genotype 3 is to use sofosbuvir plus ribavirin for 24 weeks rather than 12 weeks. Because, I'm sorry, the fission trial, which was only 12 weeks, did not show any improvement in SVR12. All right. For genotype 3 treatment-experienced patients, again, no head-to-head trials. In the Valence trial, with the 24 weeks of therapy, the SVR12 was 77%. There was no control group, but we would expect a much lower response rate to patients who've already failed PR if they had repeated PR. And again, you're interferon-free, so fewer side effects compared with an interferon-based regimen. So limitations of this that I think just you need to keep in mind when evaluating the data. In genotype 1, there are no completed trials comparing the newer drug regimens to this current standard of care, boceprevir plus pegylated interferon and ribavirin plus either boceprevir or telaprevir. Many of the trials of sofosbuvir were small and uncontrolled. This was approved by the FDA because of the breakthrough status, the impressive SVR12s, and the fact that it can be used without interferon. And then in extrapolating, you have to realize these are surrogate outcomes, not outcomes that matter to patients. So we're basing treatment on SVR12 or 24, which is a good surrogate outcome in the sense that we're essentially curing an infection, but it's imperfect in terms of really knowing how that's going to translate into clinical outcomes. We received a number of important comments. The primary comment, which, as you see, we took to heart, was that the sofosbuvir data were presented with a mix of patients with and without the Q80K mutation. So we felt it was appropriate to present the data just in patients who did not have the Q80K mutation. And the other comment was the concern that we used an SVR of 57%, 58% for the control group when we imputed a response rate in control groups to studies of sofosbuvir that were uncontrolled that we included in our network meta-analysis. And the other comment is small. So with that, I will turn the talk.
Jeff, thank you very much. I'd like to give the panel a brief opportunity to quiz you before we turn to Dan Ohlendorf. I had a couple of questions. The term network meta-analysis, not sure I understand exactly the methodology. Do you reach into these studies and sort of do a cohort analysis? I'd like you to just elaborate briefly. And secondly, the term breakthrough designation by the FDA, we're accustomed to knowing that the FDA is pretty rigorous about drugs, but when you have a breakthrough designation, what sort of compromises does that term imply?
So let's see, I'll start with the network meta-analysis. I mean, the network meta-analysis, I mean, you can get more and more sophisticated. If you do have individual level data, you can incorporate that. But in this case, we did not. It's really looking at a number of different, maybe it would be easier to go to one of the slides of the network meta-analysis. And it will be simplifying things a little bit, but I think I can explain it. If you have 3 or 4 studies comparing cimeprevir to pegylated interferon and ribavirin, and in one study, maybe you get 90% response rate versus 50%, and in another you get 60% versus 20%. You sort of estimate a relative efficacy of cimeprevir versus PR overall. You do sort of a traditional meta-analysis comparing the two and get a relative improvement of cimeprevir compared with PR. And you do the same thing with all of these other arms. And then you're able to sort of look at an average PR response rate, and based on that, calculate based on all of the studies, what the average response rate would be for the cimeprevir plus PR compared to PR, for the cimeprevir plus sofosbuvir plus PR. So it really is getting a relative risk or odds ratio here, and getting a pooled estimate for the response rate in the comparison group that's shared, and using that to extrapolate response rates across all the other groups. And so it's like a meta-analysis, but you're making some indirect comparisons between groups that aren't directly compared. And there's accepted methodologies for doing this now. It's becoming more and more common to try and understand the relative advantages of drugs that haven't been compared in head-to-head studies, but have been evaluated in randomized trials with a common control group. And then the second question was the breakthrough designation. It's relatively uncommon. I think this is the 3rd or 4th drug that the FDA has used a breakthrough designation. It has to either have marked improvements in cures or response rates, and or a marked reduction in harms or side effects, and then they will relax their usual standards of evidence. And I think we're used to seeing at least 2 large randomized trials for most drugs before they are approved for use by the FDA. But with the breakthrough designation, they relax that. And perhaps some other people can comment more on the exact level of evidence that they require. I think they look at the full body of evidence in making a decision about whether there's sufficient evidence at the time the application for approval goes before the FDA.
Are there other questions of Dr. Tice? Yes, Christine.
I was struck with your real-life SVR versus what's published in the slide number 11 when you talked about that. And that was with the pegylated interferon plus ribavirin. You said that the real SVR is probably more like 25 to 30%. That would, I assume, translate also to any regimen containing particularly interferon. Do we have any data on that?
Those, you need the drugs out there and in practice, and we need some real world observation before we can get those data. So we don't have any yet. I mean, I think people are hopeful that particularly the interferon-free regimens, you wouldn't see as big a drop, but that's a hope. That's not data-based yet.
Thank you.
Doug?
So, Jeffrey, great. I have a quick question about predicting who's going to have a bad outcome untreated. So are there risk calculators or ways that you can, risk factors you can tell us for progression to cirrhosis? And then the second question is, it looks like at least some of the trials included people that already had cirrhosis, and I'm just wondering, were you able to either qualitatively or quantitatively look at whether the treatments differed if they already had cirrhosis?
So I'll answer the second one first. That's easy. So cirrhosis is a poor prognostic indicator. So SVR 12s, 24s are always lower in patients with cirrhosis than those without. So the more pronounced the degree of fibrosis, the lower the response rates. But they are still quite high in the uncontrolled studies, as high as 80% for sofosbuvir. So they still, and the relative increases are similar for Cimeprevir in the randomized trials when you compare those with low degrees of fibrosis or no cirrhosis to those with cirrhosis. You see decrements with cirrhosis, but the absolute benefit of Cimeprevir plus PR compared to PR is similar in the two groups and similar for sofosbuvir. So you see incremental benefits in both, but the response rates are lower in those with cirrhosis. In terms of predictors of progression, there are a number of predictors. So anything else that's hard on the liver, so co-infection with hepatitis B, metabolic syndrome, but essentially fatty liver, significant alcohol intake. Co-infection with hepatitis C is a bad prognostic indicator. There are many, but a lot of it, there are a number of calculators out there, but they're imperfect.
I think we're going to have other chances to quiz Dr. Tice. I think we better go on to Dan Ohlendorf, who's going to talk about the value assessment. Dan?
Thank you, Dan, and thanks, Jeff. Let me get to my slide here. It's okay. Okay. There's probably an easier way to do this, but okay. So I won't promise to reduce any of your uncertainty, but I will go over the model of clinical and economic effects of sofosbuvir and Cimeprevir that we performed to try to get at some of the policy questions that we'll be discussing in more detail later on. So this model did focus obviously on sofosbuvir and Cimeprevir. We considered outcomes first in hypothetical cohorts of 1,060-year-old newly diagnosed patients. So these patients may have been at varying levels of underlying disease, but we wanted to reflect how patients come for treatment as much as possible. We also did some extrapolations to the entire estimated California hepatitis C population, and I'll talk about those methods a little bit later on. These cohorts were defined by genotype, similar to the way that Jeff has presented the analysis to you, the evidence review. We stratified our cohorts by genotype, by eligibility for interferon, and by prior treatment status, i.e. whether they were first coming to treatment as treatment-naive patients or whether they were treatment experienced. We adopted the perspective of a third-party payer, so we focused on reimbursements, reimbursement levels for drugs and for treatment of liver-related complications and other medical care. And we looked at outcomes and cost at 3 time points. We focused on 1-year outcomes and costs, and we also looked downstream to 2 additional time points, 5 years and 20 years after treatment. So we wanted to try to reflect the implications of the natural history of disease as much as possible. The regimens that we evaluated for each of these strata were selected to be in concordance with the recently published guidelines for each of these populations. So the AASLD, IDSA, IAS guidelines that have focused on the 3 regimens. So this is just a little depiction of the model flow. Again, relatively straightforward model using these 3 time points. The patient could appear and be treated with one of these regimens, and sofosbuvir and PR is here for illustrative purposes. Could achieve SVR or not achieve SVR. One assumption that I'll probably repeat a couple of times because I know it may be a little confusing is that we did assume some cost of retreatment in that first year for patients who did not achieve SVR in this model. However, we did not attempt to estimate the effects of retreatment. There are no data on retreatment with these newer regimens after a failed first course, but we wanted to try to give some flavor for what the cost to a payer or health system might be for a patient over 1 year, assuming retreatment for those patients who did not initially achieve SVR. And then costs were downstream were essentially focused on two types of cost. We looked at liver-related complications. So we used a composite cost estimate to look at the complications that Jeff described: hepatocellular carcinoma, decompensated cirrhosis, liver transplant, et cetera. We also found estimates of the cost of medical care, annual medical care for patients who did and did not achieve SVR. And so we assumed those costs as well for patients downstream based on whether they initially achieved SVR or not. In terms of our estimates of effectiveness, we used the results of Jeff's network meta-analysis or individual studies as necessary to estimate the effectiveness of these regimens within each of the strata. And again, the SVR from that initial course of therapy determines the outcome. We also assume that the achieving SVR would reduce the rate of downstream liver complications and lower the cost of other annual medical care. As I mentioned, the cost estimates were based on the initial course of therapy, and we used average wholesale prices or wholesale acquisition costs for those therapeutic costs. And retreatment for those not achieving SVR, again, focused on the cost only. The cost estimates for management of liver-related complications and other annual medical care for those who did and did not achieve SVR were obtained from the published literature. So some key assumptions, and we'll talk about these in a little bit of detail. So we know, based on what was just discussed, that it's unlikely that all patients would be fully compliant with and would complete their therapeutic regimen. However, we did not have any comparative data on what the rates of non-compliance would be with each of these regimens. So we made that as a simplifying assumption. Again, the costs per SVR, the cost per additional SVR achieved, and the downstream cost offsets were based on the effectiveness of that initial course of therapy. We modeled only clinical benefits related to SVR and the effects on downstream complications. So there's a bullet a little bit lower, suggesting that we did not evaluate the cost of management of side effects during treatment, for example. And we measured the cost of assumed retreatment, but not the effectiveness, as I've discussed. So we'll break out the results by genotype, really along the same lines that Jeff has done. And I just want to orient you. So, see if I can. You can't see the laser. Oh, there it is. Okay. So if you look at each of these slides, there's a call out in the upper right corner that connects you to the detailed table and page number of your handout that would have the results of interest. And for each of the comparisons we're making, we are comparing the regimens in rows after the first row to the first row. So the first row represents the previous standard of care for each of these comparisons. And you've just seen these SVRs as Jeff presented them from the network meta-analysis, so they were used here as well. The numbers in parentheses represent the duration of treatment with each component of the regimen. So for telaprevir plus PR, for example, that's 12 weeks of telaprevir and 24 weeks of PR therapy. So while we did not include estimates of adverse events or the costs of managing those events in the model, they're nevertheless presented here just to give you a flavor of how these regimens compare in terms of side effects. So with the differences in SVR, and the additional cost of treatment for the cimeprevir and sivosbuvir regimens in this comparison, the cost per additional SVR was estimated to be about $73,000 for cimeprevir, about $139,000 for sivosbuvir. Again, assuming for retreatment that patients would be retreated with the most effective regimen available, the incremental cost over the previous standard of care for cimeprevir is actually not an increment, but a small savings. And the incremental cost in this 1,000-patient cohort is about $4 million for sivosbuvir. Of note, the cost offset for 5 years down the road is about half of the initial incremental cost for sofosbuvir, and the cost offsets for 20 years down the road are higher than the initial incremental cost for both cimeprevir and sofosbuvir. So moving to treatment-naive interferon-ineligible patients, the two regimens compared here are sofosbuvir plus ribavirin for 24 weeks, and sofosbuvir, the off-label combination of sofosbuvir, cimeprevir, and ribavirin for 12 weeks. And in this case, because network meta-analysis data were not available, we pulled data from individual studies as noted below. Photon 1 and Quantum for sofosbuvir and ribavirin, and Cosmos for the off-label combination. So here you obviously see SVR rates that are much higher than the previous standard because there was no previous standard of care. The cost per additional SVR, because this is introducing new cost to the system, is higher here. So it's about $245,000 for sofosbuvir plus ribavirin, and about $172,000 for sofosbuvir plus cimeprevir plus ribavirin. We also did a combination of, a comparison of the two sofosbuvir regimens, clearly because the off-label combination is more effective. It is also less expensive, in fact, because you're comparing 12 weeks of therapy to 24 weeks of therapy. It is more effective and less expensive. But these would introduce a substantial cost to the system in this 1,000-patient cohort, between $170 and $220 million, and 35 to 40% of that cost would be offset at 20 years of follow-up. So moving to the treatment experience population, focused on patients who are eligible for interferon. So as Jeff's network meta-analysis noted, cimeprevir and the previous standard of telaprevir and PR are about as effective as each other, although there are lower side effects with the newer regimens. This is the instance where the sofosbuvir regimen estimate comes from an FDA algorithm that focused on patients who were actually treatment naive but had unfavorable characteristics, prognostic characteristics. But all three of those regimens are about as effective as each other. And the off-label combination is, again, a combination that's recommended for this population as well. So because there's much less difference in the SVR rates, you see much higher costs per additional SVR in this population. And you see that only for the off-label combination is there the potential for any offset down the road, again, because the SVRs are so close. So moving to the ineligible population, treatment experienced. So here, the estimate of SVR for sofosbuvir plus ribavirin was really our best guess. We had no treatment experience data, but we adjusted downward to relate to an expected SVR rate for sofosbuvir plus ribavirin in the absence of actual data. And again, we used the 90% rate from Cosmos. So these numbers are actually quite similar to the numbers for the treatment-naive interferon-ineligible population. We've got about 35 to 40% of these costs offset at 20 years of follow-up. Okay. So moving to genotype 2, and again, as with the results from the evidence review, this is a much simpler comparison to make for these two genotypes. So pooled data from two studies of sofosbuvir were used to estimate the SVRs for the sofosbuvir regimen and 24 weeks of PR therapy. So you see, while there's a reduction in side effects for sofosbuvir, again, this is without interferon here, you have a relatively high cost per additional SVR, in part because interferon and ribavirin is reasonably effective in this genotype 2 population, so there's not as much difference in SVR. Okay, so this would add, in this 1,000-patient cohort, about $47 million of incremental cost to the system, and about a third of that would be recouped 20 during 20 years of follow-up. So in the ineligible population, and I should point out here that there actually was initially a misprint on the slides. The cost per additional SVR is actually about $95,000. I think it was misprinted as about $330,000 initially. So the cost per additional SVR is about $95,000, again, because you have a high SVR rate compared to no availability of treatment previously. This would add a substantial amount of cost to the system initially, but the majority of that cost would be recouped by 20 years of follow-up. Okay, so for genotype 2 treatment experienced who are eligible for interferon, I apologize. Again, we took our best guess at the SVR because we had no data in treatment experienced patients. So our guess was that the estimate was that SVR would be achieved by 710 patients in the 1,000-patient cohort. With PR therapy, that would increase to 880 in the sofosbuvir plus R regimen. Because those SVRs are relatively close to each other, and due to the additional cost of sofosbuvir, it is a relatively high cost per SVR here as well. And again, about 35 to 40% of that cost would be recouped by 20 years of follow-up, according to our estimates. In the ineligible population, so we had no data moving between interferon eligible and ineligible patients. So in the absence of those data, we assumed an equivalent SVR rate to those with interferon eligibility. Here, 880 would achieve SVR, no options previously, cost per additional SVR of about $100,000 per SVR achieved. About $100 million would be added to the system through the use of this regimen. About 65 to 70% of that cost would be recouped by 20 years of follow-up. Okay, moving into genotype 3. So here it's important to point out that you will see higher cost per additional SVR here, in part because the sofosbuvir regimens are twice as long in duration as they are for genotype 2. So the FDA indication is for 24 weeks of therapy here versus 12 weeks for genotype 2. So here there's a little bit more of a spread incrementally in SVR relative to the older regimen of PR therapy for 24 weeks. But the cost per additional SVR is nearly $500,000, again, because of the cost for a 24-week regimen of sofosbuvir, using the price estimates we had available, is about $175,000. Okay. So this would add, again, about $100 million to the system relative to older therapy, and about 25% of that would be recouped during 20 years of follow-up. Moving to the ineligible population. So here we had data from positron available, but the arms of positron were so small in size that we decided to create a pooled estimate for both treatment-naive and treatment-experienced patients. You'll see that in a minute, of an SVR of 630 per 1,000. Again, compared to no treatment, the additional cost per SVR is a little bit lower here than on the previous slide, but the additional cost would be much higher because no treatment was the only option before. And here you have about 25 to 30% of cost being recouped 20 years down the road. Okay, moving to the treatment experienced population. So here you have an SVR rate for sofosbuvir and ribavirin that is, again, relatively close to the PR rate. So the SVR rate in genotype 3 with the older standard of care is a little bit lower than it is for genotype 2. But here you have, again, a higher additional cost per SVR than we've seen in some of the other comparisons because of that 24-week regimen cost for sofosbuvir. So in the ineligible population, again, we use that pooled rate of 630. So the numbers are actually identical to the numbers that were presented for the treatment-naive interferon ineligible population. Okay. Okay, a lot of comparisons. So moving from those 1,000-patient hypothetical cohorts to the analysis of potential budget impact across the state, we did some additional analyses focused on an estimate of the size of the infected population using published estimates from the NHANES survey and other sources. So our estimate of the size of the hepatitis C population currently in California is about 540,000 patients. That actually includes an estimate for incarcerated individuals and other special populations. And we assess the impact, again, within the strata that I described by genotype, by prior treatment status, and by interferon eligibility. And we base this on the change from the prior standard of care to the most effective regimen in terms of SVR rates that existed in each strata, in each stratum. We assess this alternatively for all patients who would present for treatment in the state, and for only those who have advanced liver disease. So we looked at the size of the population who would have a Medivir score, that's one way of rating liver fibrosis, of 3 or 4. So that's a subset of the entire population. So some of these additional assumptions, we assumed a percentage of patients who knew they were infected and present for treatment. That's a key issue with hepatitis C. Many don't know they're infected. So we assumed alternatively 50 and 75%. I'll be presenting 50% today. And we assumed that the proportion of patients who were treatment naive versus treatment experienced is 75% to 25%. So most of these patients were treatment naive, again, using published sources. There are lots of estimates for the proportion of the population that is eligible for interferon, or ineligible for interferon, I should say. And they vary. It varies quite a bit depending on the population of interest. So in the VA, for example, the number who might be ineligible for interferon might be much higher than this, but we used a 30% number based on some other estimates for the purposes of the modeling. And then we used published data to estimate the percentage of a prevalent hepatitis C population with advanced liver disease, and that was about a third. So this pie chart looks very similar to Jeff's. This was pulled from a published study that looked at laboratory-confirmed hepatitis C in a subset of the NHANES population. Again, just focusing on the 3 genotypes of interest for our review, about 80% of the population, this is assuming about 270,000 patients, or 50%, would present for treatment. So about 80% would have genotype 1, 13% genotype 2, 6% genotype 3. And using those results, so to orient you to this graph, we have the blue bar represents the cost of therapy under the previous standard of care over a 1-year period. The red bar represents the introduction of additional costs based on switching to the most effective regimen in each stratum. And then the green and purplish bars represent what the cost of new therapy would be after incorporating an estimate of the cost offsets 5 years and 20 years down the road. So if we look at a population in which all of the patients who have hepatitis C in California, if 50% of the patients with hepatitis C in California present for treatment, we see that the cost of about $14 billion with the current standard of care increases to over $30 billion, $32 billion to be exact, if new therapies are introduced. That cost declines slightly with a 5-year offset incorporated. With the 20-year offset incorporated, the cost declines to a little less than $20 billion. So it's still about a $6 billion increase with 20-year cost offsets incorporated. So same scale on this graph, but a different population. We're incorporating now that only patients with advanced liver disease would get the new drugs. Everyone else would get the previous standard of care. So the costs are still $14 billion under the previous standard of care, but increased to about $20 billion if the new therapies are introduced. A slight drop in those costs with 5-year offsets included, but that additional cost using these estimates would be completely offset if 20-year cost offsets were included. Again, only assuming that the subpopulation with advanced liver disease gets the new regimens. We also did a calculation using PMPM figures, or per member per month. So we used some available data from an actuarial model that's used widely in the state to determine that the average PMPM premium for an individual in a large group regulated health plan in the state is about $350. If we assume a prevalence of chronic HCV in a typical million-member plan of about 1.7%, you get 17,000 patients. And if we assume again that half of those patients would be aware of their infection and present for treatment, that's about 8,500 patients. Using the budget impact figures I just presented, the average cost increase per patient from switching to the newer regimens is about $70,000. On a PMPM basis, that's $49, which is quite substantial, about a 14% increase. The percentage increase is obviously about a third of that if only patients with advanced liver disease are treated with the newer regimens. So we kind of talked about this when we talked about the key assumptions, but there are limitations to the modeling approach, as there are with any model. We did not have sufficient data for quantitatively synthesized outcomes in many of our cases, so we had to rely on individual study estimates, sometimes from small studies, or in some cases, our best approximation given the complete absence of data. We did assume perfect compliance with and completion of drug regimens, which is not something that you would expect in the real world. And the effects and costs of drug-related adverse events, while they're presented for context, were not explicitly included in the model. We also didn't measure other potential benefits of treatment, so there may be improvements in quality of life, work or school productivity that were not incorporated into the model. So the model was really focused on budgetary impact and the effects on those major downstream liver-related complications. So we also received comments on the model. Some of these actually related to both the model and the evidence review. There was a suggestion that we consider the additional benefits of reducing the pool of prevalent infection moving forward. And we certainly agree that that's something to consider, but our focus really was on a policy-based model with the third-party payer as the perspective. So we agree, and it's sort of any more widespread modeling effort that should be considered. Patients are older and older as they're diagnosed moving forward in time, so there will be a burden placed on Medicare beyond what private payers are considering as well in the VA system. So that's something to consider. The model results are most sensitive to assumptions regarding the cost of treatment and the cost of disease-related complications. That really relates to not just our model, but any model of outcomes and costs in this population. And we got several comments suggesting other references for the cost of disease-related complications. We felt comfortable with the sources that we used because they were focused on, in one instance, on the costs for patients who did and did not achieve SVR. But some of the sources that were suggested to us for disease-related complications, for example, focused on comparisons to a non-HCV control group, which we thought was not the most appropriate comparison that could be made. Obviously, we had to lump where we could. We could not split by all possible subpopulations in our modeling effort or even in our evidence review more broadly. But there are key subpopulations to consider as well. HIV co-infection, in the treatment experienced population, which patients were relapsers versus those who didn't respond to initial treatment, et cetera. And there was a recommendation to consider some of those other benefits I mentioned that were not included in our initial model. Quality of life is one example. I think we are in agreement with some of the comments that the benefits of SVR might be more fully realized in more detailed simulation models that mimic the actual progression of disease through several states, be they asymptomatic or symptomatic. That was not something that was available to us to do, but I think we also feel confident that given the similarity of the sources that we used in our model to other sources used in other models, if those other models produced intermediate outcomes like the outcomes we're presenting here, we feel comfortable that they would be similar. And I will stop there.
Thank you, Dan.
Any
Just
questions?
just as we did with Jeff Tice, are there any questions of Dan Ohlendorf? Yes, sir.
I was wondering if you could unpack your methodology a little bit more in terms of how you measure the cost to the system at 5 and 20 years. And one question comes to mind, and this may show my ignorance of the whole thing. Do you somehow limit, for example, the number of liver transplants that could occur? And do you take that into consideration? Do you take the match issue or the availability issue into consideration? Does that falsely limit your number at a too low a number, as an example?
Yeah, I think that there's probably an infinite number of system effects that we could have modeled. So we really were much more straightforward with this. As Jeff mentioned in his evidence review, he described the benefits of SVR in terms of the relative risk reduction for those liver-related events, carcinoma, transplant, et cetera. So about 80% of those events are avoided in patients who achieve SVR. And we simply used the rate ratio, the relative risk of those events in patients achieving versus not achieving SVR to determine the rates of those events in those two subpopulations. We did not assume any additional system issues regarding availability for transplant or matching. It was really just a composite measure of the cost of liver-related complications, the rate of liver-related complications, and the reduction in that rate based on SVR.
Dr. Ranchler?
In future analyses, I would request, if possible, some estimate of compliance, because certainly the interferon versus non-interferon arms, that cries out for being addressed.
Right. No, I think that we were certainly in agreement with that sentiment, and we wished we had available data with which to assume some benefit of compliance with the newer regimens. Certainly as an exploratory analysis, we could consider that.
The studies don't state the compliance with the regimens?
There are certainly discontinuation rates in some of the studies, but again, given that a lot of the data with some of these subpopulations was actually uncontrolled, we don't really have a relative rate of compliance in these trials to consider. And in terms of categorization, I'd probably have to defer to Jeff. I'm not sure if the discontinuation rates were always that explicit in terms of reason. We know how many discontinue due to an adverse event. We know that there's typically some designation the investigator makes as to whether that adverse event was drug-related or not, but that calculation differs by study.
If I can just add on to that, but essentially the SVRs take that into account because people who were unable to adhere and didn't achieve SVR, that brings down the SVR rates to a greater extent in the more burdensome treatments. What's really missing is going from the clinical trial decrement in adherence to real-world decrement in adherence, which may be greater with the PR-based regimens than it is with a regimen that doesn't include interferon. But we have zero data on that, so we weren't able to estimate at all.
Yes.
Dan, can you speak to whether boceprevir and telaprevir are represented at all in the current RX dollars?
I'm sorry, could
The
you?
boceprevir and the telaprevir, are they
In the
is
current
that
RX
represented
bar?
in the current RX dollars?
Yes.
On
So
your charts?
if they were for genotype 1,
Right.
they were assumed to be, for interferon eligible patients, they were assumed to be the previous standard of care. So those costs were represented.
Okay.
You mentioned that in your two cost models, the second cost model is those with advanced liver disease.
Right.
Did I hear earlier that those with advanced liver disease actually have a lower response rate to lower SVR rate than those without advanced liver disease? And if so, was that taken into account with the cost model?
So in terms of the restriction to those with advanced liver disease, the complication rates, the potential for liver-related complications was increased in that population. But we did not, because we didn't have sufficient data in each of the subgroups, we did not model some lower level of SVR in each of the populations. I know in some of the trials, SVR was relatively consistent across some of the subgroups that historically might have had a lower response. So we didn't have sufficient data in each cell to be able to do that.
Last question in this section, Dr. Heidenreich.
Yes, and do you feel the 20-year offset covers the vast majority of the life expectancy? For example, if you did take a true societal approach and looked for their full life expectancy, you expect that to increase anymore?
I know that most of the natural history studies that have been performed have tried to look over a 20 to 30 year, at least in their estimation, a 20 to 30 year time horizon. Given our assumption that we focused on a cohort age 60 at diagnosis, we thought that was a reasonable approach to use. Again, not a full simulation model that incorporated the patient's entire life expectancy into the equation, but we thought this would catch the majority of liver-related complications down the road.
Two more questions, Mary.
Okay. I think a quick question. It's another one of those of the many possible things that you include in the modeling. So you started with a base case of a 60-year-old, which is in the middle of that age cohort of those born in 1945 to 1965 that account for about 75% of the cases at present. And so that seems like a good place to start. But if you follow them for 20 years, you get to 80-year-olds, where you have very substantial competing morbidities and mortality.
Right.
Like in Medicare in 2010, 2/3 of the patients had at least two comorbid conditions, and more than a quarter of them had 4 or more comorbid conditions. And so how did you handle all the competing morbidity and mortality risks in the model?
We handled it by not considering it. So essentially, we did get a public comment about this, and it's certainly the case that were we to fully simulate this population and try to understand those competing risks, we would have incorporated those types of elements. But because we were focused on the incremental differences between treatment regimens, we felt that, and again, focused on liver-related complications as a downstream event, we felt that if we had data that provided the effects of that increment from previous standard of care to a sofosbuvir regimen, for example, on those events, the outcome data that we would always aspire to get and that we don't have, we could have incorporated that into a model like this, but we simply didn't have that information. So we chose, because we didn't have evidence that there was a differential effect on some of those harder outcomes, we focused really just on a uniform rate of liver-related complications and the effects of SVR on it.
Dan, can I ask you just to follow up on that? What do you think would have been the effect on the cost offsets if we were also trying to model the deaths of patients from other conditions? So not so much the comorbidities, but the mortality of patients as they get into their 70s and 80s.
So the cost offsets probably would have declined, given that there would be attrition of the cohort over time. But again, I don't think there's any reason to believe, at least at this point, that the decline would be differential for one regimen versus another.
Dr. Redberg?
Thanks. Can you just give me a better idea of how the population we modeled compares to the population in the clinical trials in terms of identification? Because my understanding, we're talking about a screening hepatitis C, so most of these patients don't have symptoms. So I'm not clear on how they were identified for the trials and then how that would compare to the person in your model.
So the two components of the model operated a little bit differently. So in the first component, where we have the 1,000 patient cohorts, we're really kind of mirroring the effects in the trial populations, because that's where we obtain the SVR information from. For the prevalent population analysis, the budget impact analysis, we simply took an estimate. The estimate that we took was an estimate of patients with chronic hepatitis C. Because so many of those patients don't know that they have disease at this point, we notched that down using two alternatives, by 50% in one case, by 25% in another, and then assumed that that population would be aware, the remainder population would be aware of disease and would be at their doctor asking for treatment.
Just to drill down, I'm still not clear on how, for example, the patients in the trials were identified. I mean, it struck me that, like, the trial had 97 sites, but only a few hundred patients, so just a few people per site. And so they must have been winnowing down very significantly, and I'm wondering.
Jeff, do you want to speak to that at all in terms of patient identification?
Let's see. Yeah, this is on. No, I think that's certainly a concern. These most likely are more symptomatic patients as well, and they're patients that are identified. If we're trying to extrapolate to patients who are now being identified by current screening, it's likely that the screen-identified patients would be less sick because they haven't come to care yet. But we would have to really compare the patient characteristics.
I'm just interested, I think it's an important point whenever we talk about screening in healthy populations, sort of, what is going to be the benefit to take someone who's totally healthy? Because I was struck, I was at the hotel gym on Friday and there was a big ad on the TV from Gilead saying, I should be screened for Hep C. And you think that's going to expand the net quite a bit to start screening healthy people. So I'm just wondering if we can extrapolate that kind of a direct-to-consumer advertising approach to the approach that was taken in these clinical trials.
I'll speak for Steve here. I think that's the kind of thing that would be good for the policy roundtable because it's really hard to extrapolate. I think many of the hepatologists who will be on the panel can also address sort of who they think we should be prioritizing, what other tests we should be looking at before deciding whether or not to treat somebody who's been asymptomatic for 40 years, say, after their infection.
Yes, many of these questions we will return to later. We do have three people who wish to make public comment, and I would invite them to come up to the table. There's Dr. Saab, Sammy Saab. There's Rachel McLean and Jesse Brooks. And we're going to continue this discussion until noon when we have a working lunch. But if you could limit your introductory remarks to, say, 3 minutes, each of you, and we'll start with you.
I'm Sammy Saab. I'm a liver doctor at UCLA. And first, I want to give my disclosures. I'm an advisory board and consultant for all the hepatitis C drug companies, AbbVie, BMS, Janssen, Gilead, Merck, and Vertex. I'm a professor of medicine and surgery at UCLA. I've been there for about 12 years now, and UC is one of the largest transplant centers in the world, and I've personally treated over 1,000 patients with hepatitis C. I'm also head of outcomes research at UCLA in liver disease and worked in quality health instruments, worked on network meta-analysis, as well as numerous cost-effective studies over the past decade. So as you know, hepatitis C is a leading cause of cirrhosis in this country, leading indication for liver transplantation, and one of the most common underlying causes of liver cancer as well. In Los Angeles, hepatitis C-related discharge from the hospital have increased threefold between the years 2007 and 2009. And the CDC recently highlighted that the hepatitis C prevalence is decreasing, not because of effective medication, but people are dying off and mostly from liver-related mortality. Sofosbuvir, one of the new drugs approved, represents a major leap in hepatitis C therapy. It's safer, more efficacious, simpler than anything we've had before, and addresses major unmet needs, like treating African Americans, cirrhosis, people who are HIV co-infected, people waiting for liver transplant. For instance, people who have cirrhosis before had a cure rate of 23% with interferon ribavirin. When you added boceprevir, it was 50%. Or Telaprevir was 60%. With sofosbuvir for a quarter of the time, it's 80%. HIV co-infected patients, the first time we've had a drug approved for hepatitis and HIV at the same time. The cure rates are the same as mono-infected patients. In African Americans, this group has the highest hepatitis C prevalence among any minority group, has the highest death rate from hepatitis C, and the highest liver cancer risk of hepatitis C. The cure rates with interferon with ribavirin was only 23%. Today's 87%. Cost-effective models are used to compare cost efficacies of different diagnostic therapeutic interventions. The accuracy, validity, and generalizability depends on assumptions and data inputted. And unfortunately, there's some issues with the current model that are used by the committee. First of all, the transition rates are based on a single study that's over 10 years old. And this will underestimate the cost of social liver complication. I also have trouble with the SVR rates. And the SVR rates in the model are about 10% lower than was seen in the phase 3 trial with sofosbuvir and ribavirin. And this will underestimate the benefit of antiviral therapy. And as you mentioned, any model is very sensitive to estimates of therapy. And the network analysis, one of the patient characteristics were used. We're considering that in the study with sofosbuvir, there's a large number of individuals who have cirrhosis and high BMI and were African-American descent. In the model, I'm concerned also because the cost of liver complication appears to be lumped together to a single value of $20,000 to treat liver complication, which seems exceedingly low when you consider the cost of being in the hospital for 1 day could be $2,000 to $5,000, and the ICU between $5,000 and $10,000 per day. And these costs of complication pale in comparison to studies provided by Gordon and McAdams published recently in peer-reviewed journals. And of course, any problems with cost will underestimate the benefits of antiviral therapy. I also have trouble with the number of patients to be treated as being 50%. Seems exceedingly high when you consider less than a third of patients with hepatitis C know they're even infected. And I don't know of any other disease state where we see a treatment rate of 50%, whether it be diabetes or hypertension or high cholesterol. Patients just don't see their doctors.
One more minute, please, with your opening statement.
Okay. The other issue is Q80K was ignored in the model, and that's a mistake. The most common genotype subtype is 1A. 30% of 1As have Q80K, and there's no advantage added to imipivir to these patients. The response rate is the same as interferon ribavirin. Other issues, we have no data managing adverse effects, work productivity, and quality of life are not considered. Probably stop here.
Thank you very much. Would you make your statement, please?
Sure. Hi, my name is Rachel McLean. I'm the Viral Hepatitis Prevention Coordinator for the California Department of Public Health, and I have no disclosures. Thank you for the opportunity to provide public comments today. Hepatitis C is a significant public health problem in our state. Interferon sparing regimens may make hepatitis C easier to treat and cure in a primary care setting and have the potential to prevent further hepatitis C transmission, which is something that hasn't been considered by this panel, but this is a public health problem, so I'm providing a public health perspective. However, these gains can only be realized if screening and treatment recommendations are widely adopted in clinical settings. Yet many health professionals lack experience in hep C treatment, screening, and diagnosis. That's why the State Hepatitis Prevention Strategic Plan includes a number of recommendations on increasing access to viral hepatitis care, such as by allowing primary care providers to be reimbursed for viral hepatitis screening, evaluation, treatment, and care, identifying opportunities for increasing hepatitis C prevention, testing, and care in federally qualified health centers and county indigent services programs with the availability of specialty consultation, and creating or expanding drug assistance programs for low-income individuals, including those with hepatitis C. And this just builds on Dr. Saab's point. California Department of Public Health analysis of state data on hospitalization charges from 2007 to 2010 found that hepatitis C-related hospitalization charges for liver disease, liver cancer, and liver transplantation increased from $1.7 billion in 2007 to $2.3 billion in 2010, a 36% increase. Baby boomers accounted for more than 3/4 of those charges in 2010. These costs and complications can be prevented or mitigated by early detection, hepatitis C treatment, and lifestyle changes. Many people with chronic hepatitis C were infected 20 to 30 years ago and have developed complications from the disease. For some of them, treatment can't wait. I am available for follow-up questions, and thank you for your time.
Thank you very much. Do any of the panelists have questions, either of the two speakers, or wish to make any other comments? Yes, I see that our third guest wishing to speak didn't show up, so any... Jeff, you or Dan have responses?
Are we out? Good. I think, one of the comments was about excluding the Q80Ks, and I think we did already incorporate that in the updates for the meeting today. And we certainly are aware about the potential for reduction in transmission, and that's an additional benefit, probably modest from the perspective of the payer, but from the perspective of society long term, a real benefit to more aggressive treatment.
I think both speakers suggested that the costs of treatment were underestimated in the model. Dan, any comments on that? Complications, yes.
One clarification I wanted to make is that the cost of liver-related complications was not $25,000. It was $25,000 per year. So we assigned that cost to each. We did discount the cost in future years, but we assigned that cost to each of those 20 years, even though in reality some of those complications and most of those complications would occur at the end of that time frame. So I think you could probably make an argument either way. It's certainly the case that some of those events are much more costly than others. But again, we didn't pull the estimate out of thin air. We did pull it from a Medicaid study looking at a cohort followed over a certain period of time.
Question? Statement?
So from the model, I'm assuming that when we said that 1,000 in the cohort, that they were all eligible for treatment. But if you looked at some of the exclusion for treatment, do we have an idea of the cohort in real life who'd actually be candidates for treatment?
You're talking about the interferon eligibility issue, or?
From some of the data that they gave us about the candidates for treatment, like for example, if you were alcohol user or statin user or diabetes, things that are relatively common would make you not a candidate for some of these new therapies. And I just wanted an idea, do we know what % of the cohort would not be a candidate? Would be a candidate, put it the other way around.
I think there are very few exclusions based on the new drugs. I mean, it's interferon that has the biggest set of restrictions, and so there are very few additional restrictions based on any of the new drugs.
I had a question. After SVR, what about reinfection? Are there subgroups of patients that are particularly prone to reinfection? Any comments?
That's a very unstudied area. There are some data reinfection rate tends to be in people who were first infected with drug use, and the gay population as well. But most of the data comes from injectable drug use. Most of the studies are from outside the United States, in particular Australia, for some reason. But drug use is it's a part of the major reason why people are reinfected. Having been cured once does not give any protection against reinfection. Does not.
So would that be a contraindication to therapy if somebody were a known drug user?
There's a lot of contraindications: compliance, adherence, following recommendations, family planning, work schedules, drug use, alcohol use. That's why the 50% treatment rate, it's very, very high. I mean, figure in past 15 years, we've treated less than 9% of patients in 15 years. So all of a sudden, in 6 months, you can treat 50%. You know, we don't have the resources, we don't have the staff. And I think some of the panel brought up earlier, we have to be selective who we treat. Most of the benefit that was shown earlier, most of the benefit of being cured, people with advanced disease. When someone comes to my office and they have advanced disease, I could tell them you're going to live longer by curing hepatitis C. If they have stage 0, stage 1, I can't make the same claim because they could die of a competing cause, of a stroke, of a heart attack, or something else. So knowing the severity of liver disease is very important for us as well. And I don't think that was brought into the model. I think the model assumes everybody, the decision analysis model, I don't think it's a Markov chain, it's a decision analysis, it's a simple model, simple decision analysis model. It's not very complicated, it's very simple. That was not considered, the severity of liver disease in the cohort individuals. 50% treatment rate is really high. I mean, do we treat 50% diabetics patients or hypertension patients in the United States? We don't.
I just wanted to add that the National Institutes of Health in 2002 issued a policy that treatment of drug users should be made on a case-by-case basis between the doctor and the patient. And then there are models of successful treatment of active injection drug users. There are data from Scotland in particular that show that if you provide comprehensive services that include opiate replacement therapy, for example, such as methadone or buprenorphine, syringe access, Hep C treatment, sort of a comprehensive model. 68% of people with Hep C were infected through injection drug use, and I would hate to see that entire population left out of the benefits of these new treatment drugs.
Thank you. Yes.
I'm interested, we talked about the perspective from a third-party payer, but we didn't distinguish between private insurance versus public insurance. And your testimony from the Department of Public Health prompts me to think, I wonder what proportion of this population, in fact, is on Medi-Cal. And given the state of Medi-Cal these days, I was curious whether your department talked at all with the Department of Healthcare Services and what this would mean for the Medi-Cal budget in particular. But so my first question is, do we know of this population, how are they generally split between private insurance and public insurance?
We've been working with Medi-Cal to try to develop estimates of the prevalence of hepatitis C in the Medi-Cal population, and NHANES just put out some data stratifying prevalence by income. And we've submitted a request to the authors of that paper to get further stratifications by sex and age and race ethnicity. Sarah Royce is here from Medi-Cal, and obviously we can't speak to any policy decisions, but we are trying to help them develop prevalence estimates. I know there was one study, and I don't have it in front of me, that showed that people with Hep C were just more likely to be uninsured than people that didn't have Hep C. I think the Affordable Care Act will probably change that. And, in California, if expansion is fully implemented, then people that are low income should hopefully get coverage. And we would expect that the prevalence in the low income population, based on NHANES at least, would be higher than in the higher income population. And that would probably correlate to some degree with public versus private payers. Although I think it's important to note that a good proportion of the baby boomer population is aging into Medicare, and that is not dependent on income, it's just based on age. And I think, over time, a good chunk of this population is going to be covered by Medicare, and they'll be the ones that'll be assuming the costs of Hep C treatment.
Yes, Christina.
Question for Dr. McLean. You mentioned the patients. Oh, okay, sorry. You mentioned the patients infected with hepatitis C and the risk of them transmitting hepatitis C to others. Is there a rough ballpark number of the average rate at which that occurs?
I don't know if I've ever seen that data done. I know the UFOs, there's a cohort study that's actually out of UCSF here in San Francisco that's looked at incidence rate among young injection drug users under age 30, but I don't know if I've ever seen sort of a an R analysis of, for each person with Hep C, this is how many people they infect. I think it depends on their risk behaviors. If you have somebody with hepatitis C who doesn't inject and hasn't for 30 years, the chance of them transmitting it to somebody else is low unless they're, sharing razors with people that they live with or that kind of a thing. I mean, there's probably some transmission. There have been acute hepatitis C outbreaks in long-term care facilities due to lack of infection control. So I would think that the transmission that would happen in this population is probably more likely to be sort of accidental in that way. Not that it's ever intentional, but I'm not sure. I can look and try to find out.
Yes, Rita. Dr. Redbrook.
Rita's fine. I just thought Mary had a question too, but I'll go. So I was back to the models just because, as everyone knows, the inputs in the model are really important in terms of predicting, getting the numbers right, and we are left to a lot of modeling because the studies were fairly short term. And I'm struck your last comment that if you have a patient with advanced liver disease, you're more confident in knowing there's going to be a benefit. But I'm wondering if you could give us some idea from the data on sort of the healthier person with who's discovered to have hepatitis C because of a screening, but didn't have any symptoms, may not have any liver disease at all, but what is their chance of going on to get hepatocellular cancer and dying of it, and how would that be changed by this regimen of the newer drug that we're talking about, sofosbuvir?
I think this is a propitious time to call it. We have an expert panel that's going to be deliberating that very issue this afternoon. So let's take a break now. Shortly, there will be a buffet lunch in this room, and we'll have a working lunch. Thank you.